So we're going to talk about diabetic neuropathy. We work in Newham Borough in London, England. We have one of the highest rates of amputations in the country. Our recent audit showed that there was a significant number of referrals to our podiatry clinic for diabetic foot problems with neuropathy and no other described features. This encompassed a wide variety of patients, from low to higher risk groups. We felt there was a real opportunity to provide education for healthcare professionals of all stages so that we can help improve patient care. So diabetic neuropathy is really important. It affects around 50% of patients with diabetes at some point in their life, and there's a real risk of ulceration and amputation. Most management is actually self-care by the patients themselves. They're only going to see healthcare professionals a few times a year, and in between those times we need to ensure they know how to monitor their feet and act upon any changes they find. Similarly, most care is in the community through primary care, through patient education, management of symptoms such as neuropathic pain, and referral onwards should complications arise. So how do we assess patients for neuropathy? This is usually assessed at the annual diabetic review. Patients may come complaining of a wide variety of symptoms. They may feel burning pain or pins and needles in the feet, or they may not feel heat as normal, for example hot water in the shower, or may not feel their feet hit the floor. Then you need to examine the patient. Look carefully at the feet for any changes in the skin, such as callus formation, breaks in the skin, or dry skin. It is crucial to look for ulceration, which would require urgent attention. Look at the nails for any pathological changes, such as ingrown toenails. Then examine the vascular status by feeling for the dorsalis pedis and posterior tibial pulses. Then, lastly, we go on to examine sensation. So examining sensation. The gold standard really is to use a 10-gram monofilament. This is used by applying the filament with just enough pressure to create a bend and hold it there for 1 to 2 seconds, asking the patient if they can feel it. You examine this in 5 areas on each foot. This is the tips of the first and third toes and the heads of the first, third and fifth metatarsals. You then examine more proximally if there is a deficit to establish just how severe this is. Ideally, you should also use a 128 Hz tuning fork to examine vibration sensation. You start at the distal interphalangeal joint and move proximally again if there is a deficit. Lastly, if neither of these are available, you can use the Ipswich touch test. This is done by pressing lightly with a finger for 1 to 2 seconds at the tips of the first, third and fifth toes and asking the patient if they can feel this. So what do we do if we can't feel a pulse? These patients will need a vascular referral, but it is still important to look for further evidence of vascular disease. They may complain of symptoms such as intermittent claudication. You may see signs of vascular disease, such as cool or pale skin, or even tissue loss and ulceration. In these latter cases, these patients need urgent vascular review, usually as an emergency. So what can patients do? This is actually the most important part of managing neuropathy, as they're only going to see healthcare professionals occasionally, and this leaves several months where a lot could happen. The first thing is to make sure patients check their feet daily. They're looking at the skin for callus, dry skin or ulceration, and at their nail condition. They also need to ensure they check their feet for any foreign bodies, like stones inside them. They should avoid walking barefoot, including in the house, and also avoid heat. A lot of people use hot water bottles, However, they lack pain sensation and so won't feel the temperature or notice that this is causing tissue damage from the heat. They also need to ensure they have properly fitting shoes. This includes occupational footwear, which is made to protect from dangers at work, but may cause pressure or friction on certain areas of the feet. A podiatrist may be needed to adapt specialist footwear. Lastly, they need to know when to seek help, and if they have an ulcer, then they should seek urgent medical attention, or if it is large or they feel unwell, go straight to the emergency department. Neuropathic pain can be a real issue for patients. It can be excruciatingly painful, keep patients up at night, and have a real psychological impact. There are 3 main groups of agents we can use for management: duloxetine, amitriptyline, and pregabalin. It is important to note that pain can occur before sensory loss, and so we should consider neuropathic pain even in the absence of objective sensory deficit. All of these medications should be up-titrated to achieve the maximal symptomatic relief whilst minimising side effects. Duloxetine is probably the best drug for neuropathic pain. It has the added benefit of being a selective norepinephrine reuptake inhibitor and acts as an antidepressant as well. We start at doses of 30 mg and can up-titrate after a few weeks to 60 mg. It's important to be careful in cardiovascular disease, and there is a potential risk of precipitating arrhythmias. Amitriptyline is a tricyclic antidepressant. We start at very low doses of 10 mg, and there is a wide scope to up-titrate to. We need to be careful as it can have antimuscarinic side effects, including constipation and urinary retention. It can also cause delirium and precipitate acute angle closure glaucoma. Lastly, we have pregabalin or gabapentin. This is a controlled drug, and one of the side effects is dependence, so this needs to be monitored for carefully. It can also cause significant drowsiness, and so caution must be taken, particularly in patients with liver disease, for example, where it could precipitate an encephalopathy. We start at a dose of 75 mg twice per day with pregabalin and titrate upwards as tolerated. So when should patients be referred to podiatry? Diabetic patients with significant callus need to be referred, which may need trimming down to prevent progression to ulceration. Those with pathological nails, which cannot be managed at home, need referral. Some patients need specialist footwear to reduce the risk of friction and later ulcers on their feet. The higher risk group is patients with neuropathy or non-critical limb ischemia, as well as other features such as callus or deformity, as may occur in motor neuropathy. Any patients who have had past ulceration or amputation also need to be carefully monitored in the podiatry clinic. This is not an exhaustive list, and there are other indications, but these are the most common.